Okay, so I'm just going to talk to you today about my PhD study, which is looking at speech and language in Dravet syndrome. So a very big thank you to the families that were involved. So previous to this study, we really didn't know a lot about speech and language skills in Dravet syndrome. There were a few studies in the literature where they'd examined language as part of a broader neuropsychological battery. So you had neuropsychs looking at language skills, and the findings were really variable. So it wasn't really telling us a lot about language skills. And there are only really anecdotal reports of motor planning and motor speech production problems. So the aim of my study was to look at speech, oral motor skills and language in Dravet syndrome. So speech, as I said, is how you produce sounds. Oral motor skills is how you move your articulators, so your lips, your tongue, your jaw, in both speech and non-speech tasks. And then language is how you use words and how you put words together to make sentences and use correct grammatical structures. So I was interested in looking at all of these things in patients with Dravet syndrome. So I was really lucky to have 20 patients that had agreed to be part of the study. I looked at a wide range of ages and abilities, and all the patients that were involved in my study had mutations in SCN1A. And I put the patients into two groups depending on their speech skills and also their ability to engage in some assessments with me. So my assessments were really tailored according to the patient's abilities. So in the patients that I put into the minimally verbal group, I did a behavioural sample, so I videoed them interacting with their parents, interacting with some favourite toys, singing, those kinds of things. And in the verbal group, these were some patients who had speech and they were able to engage in some standardised assessments. So I did some assessments looking at how they moved their mouth, how they produced the different speech sounds, and then how their use of language and also their understanding of language. So in the minimally verbal group, I used the behavioural sample and I looked at the different behaviours, the communication behaviours that the patients had, and I used a rating scale to rate the behaviours. And so all of the patients had intentional communication. So some of the patients, and I showed a video just before the break of a little girl who had pre-intentional communication. So there were some patients that could use eye contact and vocalisations, and also there was another patient who was using his mother's hand as put her hand on the door to say that he wanted to get out of the assessment room with me. And there were also some patients who were able to use single words or signs that I could recognise. In terms of oral motor function, so how you use your lips and your teeth and your tongue, so all but 3 of the patients had really significant impairments in oral motor skills. I mentioned before about these difficulties with sort of keeping correct posture, so maintaining stability in the trunk and the neck and the head. So that affected over half of the patients. There are about 8 patients who had saliva control issues, but all of them were on medications that a side effect is drooling. So it's difficult to know what is the medication and what is their impairments in oral motor skills. And about a quarter of the patients had reported some mild swallowing problems. So when I did these oral motor tasks, I found that the lip and tongue movements were impaired, so the patients had their movements were either reduced or they had some asymmetrical movement, or they had difficulty coordinating their oral motor movements, and their posture really impacted on their ability to perform the oral motor movements accurately. And they also had some really striking problems with planning, so if I asked them to stick their tongue out, so really being able to plan where their tongue needed to go So I've just got a little video just to illustrate the different impairments. This is a gentleman just with an open mouth posture at rest. So I've asked this little boy to smile and he's having trouble. So having real trouble with rounding her lips. This is just to illustrate the problems with planning. So planning, I asked him to stick out his tongue and he's having real difficulty just being able to plan where his tongue needs to go. This little girl really had trouble even elevating her tongue. And lots of associated movements to try and support the oral motor movements. Okay. So all of the patients in the verbal group had dysarthria. So I talked to you before the break about sort of what dysarthria is. So when I looked at all the patients, how they performed in conversation and different speech tasks, I heard some features that was consistent across the patients. So they all had, they didn't have enough breath support for speech, so they were running out of breath as they were speaking. And that's really important because, as I mentioned, the breathing really sort of drives the rest of the speech system. So with producing voice, so at the level of the voice box, they all had either a breathy or a strangled sounding voice. And in most of the patients, I heard a vocal tremor. I won't try and show you what that means. I'm not very good at that one. They all had difficulty articulating consonants and vowel sounds correctly. And so resonance is this how the sounds are shaped as they go through the mouth and the nose. And so they all sounded like they had a cold, or sorry, almost all of them sounded like they had a cold. So that's called hypernasal speech. And when I looked at sort of the rise and flow of speech, all of them would put stress on normally not stressed parts of speech. Most had a very slow rate, shortened phrases, and of course that's complicated by not having enough breath support for speech, and sounding a bit monotonous when they were talking, so not really having that rise and fall as they're talking. So I've just got some videos to show you, first of all, what this little girl, she's got a mild dysarthria. So if you just listen for her, how she's got some age-appropriate sound substitutions, but also some sounds are distorted or omitted, and she's got a very soft volume with her voice.
Who's Bailey?
Brother.
Your brother. Is he older than you or is he younger?
Younger.
And who else?
April and Melanie.
April
Melanie.
and Melanie?
Madeline.
Madeline. And who are April and Madeline?
They sisters.
Your sisters. And soon there'll be another new baby. That's exciting.
Mama is carrying the baby.
Yeah.
Where's the baby?
Okay, and this is a gentleman who's got a severe dysarthria. So he's got a very wet sounding voice, he's got a very slow rate, and you can really hear his difficulties with articulation.
It's Claire's birthday.
Claire's birthday? Today?
No, soon.
Ah.
Say, I'm going to get the birthday cake.
Well, that would be nice. What kind of birthday cake?
Chocolate.
Delicious. Is that your favourite?
Let's go on the picnic.
Gonna go on a picnic? It's a bit cold for a picnic.
Claire is.
Claire's gonna go on a picnic.
Here's candles.
In terms of language skills, all but the two youngest children in the group had receptive and expressive language impairment, and the two youngest were 15 months of age when I saw them. And then that's just a summary. So oral motor impairment was a common finding in this group of patients. I heard distinctive features in their speech that would help to diagnose the dysarthria. Language skills were generally at the same level as their cognitive skills. I haven't talked to that in very much detail. And then the individuals who didn't have speech had intentional communication, so they had the potential to communicate. And understanding these features is really important for us as speech pathologists to be able to accurately diagnose and also plan interventions. And I've been really fortunate just in the last week to be lecturing with the Masters of Speech Pathology program, and I actually talked to them about this study. So this new generation of clinicians coming through, having them be more aware of these speech problems in these patients. So thanks very much.
Thanks, Sam, and we do need more academic speech pathologists like Sam. I think it's a whole new area, and that goes for all the allied health areas like physio, OT, dietitians, psychologists. We need a lot more academic people to think more deeply about things. It's a beautiful example. There's one question. If there are anybody here with a question, put your hand up now and Alison will run to you. Thanks. And there is one question from Rana, who asks from Australia, Sam. The question is, at what age should a child with Dravet syndrome have a speech pathology assessment?
I would recommend that you have speech pathology involvement from as early as possible. So these children should be eligible for early intervention. So I'd get into an early intervention service as soon as you can.
So what's as early, 1, 2?
Well, as soon as you get a diagnosis. But I mean, if they're diagnosed a bit later on, once they're showing that they're having difficulties, so sort of in the second year of life.
Second year of life probably would be. And Georgie?
Is there a style of speech pathology that you would recommend, particularly for low muscle tone? So if they can't close their mouth, so their articulation isn't great, is there a kind of speech pathology or a specialist that we should be looking for to help our children to increase, I guess, their ability to be able to move their mouth and those sorts of things?
Yeah, so in terms of sort of dysarthria treatment, if you were seeing a speech pathologist who specialises in dysarthria, I mean, as I said before, there's not really any, so those sort of oral motor exercises that are not speech specific don't really help with speech. There's not really any evidence. So really the treatments that we've got are the ones where we're looking at breathing, looking at speech volume, looking at the children projecting their voice and other strategies to help them be more intelligible, so being more able to be understood. So that's sort of what we've got in terms of treatments.
Thank you very much. Oh, there's one more over there and then we'll have to move on.
My question was in relation to strategies as well for developing language skills. You're saying that often the child's cognitive ability is congruent to their language skills. I've just found with my son that some of the strategies for language skills are often you need a lot of cognition to be able to follow those activities. Is there any particular type of strategies that are better for our kids when they have difficulty in those areas?
I've found that using visual supports are really helpful, because it's if you're just getting verbal information, I think that's not enough. So I think for this group of kids, having information from other sorts, so visual information or tactile information, just to help them with their comprehension when you're doing language activities. I don't know if you, in your therapy sessions, whether you're using visual schedules or you've got other visual supports there. So it's not just about the speech, they've got other things to help them.
Great. Well, please thank Sam for her. Thank you.